Welcome to It's Your Case, presented by VetCT.com. I'm Amy Zalcman, your radiologist on demand for this week. We are in our final week of this month's theme of fluid. Today's case is a 10-year-old male entire Boston Terrier who has had acute collapse and pallor and now has labored breathing. The cardiac silhouette is increased in width on all views. We also observe that it has a generally round shape on all views, with loss of distinction of the cardiac apex. The cardiac silhouette is increased in height, which results in dorsal displacement of the terminal trachea. There is generalized increased sternal contact of the cardiac silhouette. And if we draw an imaginary line from the terminal trachea to the region of the cardiac apex, we have a disproportionate volume of soft tissue cranial to that margin, suggesting an increase in the right to left ratio of soft tissue. The pulmonary vessels are relatively normal in size. The remaining findings will be discussed in the report. Our principal conclusion for this patient is generalized cardiomegaly with primary roundness of the shape and equivocal right-sided enlargement. If we take a step back and consider that the patient presented for collapse, we acknowledge that these can be either neurologic events such as seizure or may be cardiogenic. The finding in this exam of cardiomegaly that is specifically round gives us a clue that this patient could have collapse associated with a cardiac disease or a process involving the heart. Cardiomegaly is nonspecific and most often in small dogs of advanced age can be observed secondary to mitral valve insufficiency. However, our Röntgen signs associated with mitral valve insufficiency include left atrial dilation and left ventricular enlargement, which is not observed in this exam. So we have to then consider other differentials. We also recall that the cardiac silhouette is comprised of the heart, the pericardium, and a small volume of pericardial fat. With many diseases, even including left-sided enlargement associated with mitral valve disease, the cardiac silhouette still tends to maintain a classic shape. It is important then that we note that the cardiac shape is rounded. This can suggest distension of the pericardial sac with a small volume of fluid and therefore distorts the shape with relatively mild enlargement of the cardiac silhouette. When physiologically substantial, the lower pressure system of the right side may not adequately fill in diastole to maintain the output of the right ventricle, and this ultimately can create a domino effect to the left side, ultimately decreasing cardiac output and then resultant syncope. The constellation of these changes is termed tamponade. Our next steps for this patient include an electrocardiogram, or EKG, and an echocardiogram. A TFAST in this patient identified that there was anechoic fluid surrounding the heart. Causes of pericardial effusion are variable. They can be malignant masses associated with the heart base or right atrium. We can also observe this associated with chronic and often severe heart disease, or effusion can be idiopathic. Ultimately, this would necessitate sampling of the fluid for cytology. However, we must consider risk-benefit ratio. Be sure to view the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.